Our next speaker is Dr. Rajendran AJ, Senior Consultant and Clinical Lead Rehabilitation Medicine. Current workplace is MGM Healthcare. His area of interest are special interest in heart failure and transplant patient. He has trained in post-transplant rehabilitation. So we welcome Rajendra, please.
Hey everyone, I'm Dr. Rajendran, physician, greatly interested in cardiopulmonary rehabilitation. This is our Indian Association of Physical Medicine Rehabilitation heading towards a Golden Jubilee celebration next year. At Johns Hopkins University Hospital in Baltimore, USA, we have Dr. Dale Needham. Dale Needham is a pulmonologist and a physical medicine rehabilitation person, and he conducts annual conferences and shares his knowledge through various websites which I have given here. And the role of a rehab physicians in the critical care scenario is supposed to anticipate, prevent, or minimize the deterioration of our patients, plan an individualized rehabilitation plan to get him back to near normal quality of life, and interact with the multidisciplinary team. We're supposed to build a robust rehab team to provide an optimal and holistic rehabilitation program. Holistic in the sense, take into account the physical impairments as well as the cognitive impairments and the mental health issues associated with the patients as well as their families. Teach and train the new recruits. In an ECMO ICU, we can expect a lot of prolonged ICU stay and morbidity associated with that, like for example a muscle loss, muscle weakness, contractures, respiratory and sensory problems, pain, swallowing, communication problems. Non-physical modality in the sense psychological, emotional, psychiatric problems and cognitive dysfunction. Quality of life in adult survivors of critical illness is becoming a hot topic, and everybody wants to, they started demanding that there is better quality of life that they want from their patients. Dr. Hiroshi Nagashima, Director General WHO, in the years 1988 to 1998 said, increased longevity without quality of life is an empty price. How do we give this? We form a good team, rehabilitation team. We have the physiotherapists, occupational therapists, we have the respiratory therapists, speech therapists, clinical psychologists, and the nutritionists supporting us. And we team up with the multidisciplinary team in ECMO ICU to make decisions regarding mobility. Early mobility is definitely considered as the best thing for our patients. What can we do? We can do a lot of things in the respiratory therapy, the bronchial hygiene, breathing exercises, coughing techniques, and incentive spirometries. And in the musculoskeletal therapy, balance issues, prevention of fall, strengthening exercises, and progressive ambulation programs. Not to forget the relaxation therapy, which is very important for them to cooperate with us, and supported by the nutrition therapy. So the physiotherapists and the respiratory therapists have an important role in positioning and repositioning the patients in order to prevent pressure sores. We have a lovely paper here, an expert consensus and recommendations on safety criteria for active mobilization of mechanically ventilated critically ill adults. And you will find the name of Dale Needham in most of these papers, and that's what I said is from the Johns Hopkins. So we have a very clear demarcation of in-bed exercises and out-of-bed exercises. Also, when the blood pressure is fluctuating, bradycardia, and transvenous or epicardial pacemakers. The right-hand side shows the femoral IABP, and there is a green signal that we can proceed with IABP patients. And ECMO patients, when the femoral or subclavian, not single or bicaval dual lumen cannula, we can still proceed. And also, in the end, we will find that ICU acquired weakness, we can proceed with in-bed exercises as well as out-bed exercises. Continuous renal replacement, CRRT, we can still do the out-of-bed exercises with great care. This is a game changer. LETTO cycle movement therapy is a game changer. We have this machine with us, and it's a computerized machine made in Germany. We can exercise our patients even if they are in the not awake state, like ICU not awake, but still we can go along with this. There's a huge trial coming up in Canada. It's been going on with great support and excellent funding from all the organizations in Canada. We call it the ICUcycle.com, and they share all the knowledge. And they are supposed to tell us that early in-bed cycle ergometry with ventilated patients is a safe procedure. They've already done this, and they've published many articles. ICU mobilization, we have a scale, ICU mobility scale. We have 0 to 10 here. The no mobilization or passively exercised thing is 0, and then it goes on to out of bed, chair sitting, standing. When it comes to standing, it is the best thing because of the weight bearing activities, and we get the best benefits there. Next comes standing and marching and walking. Not all patients will be cooperative when we go. Most of them will cooperate, but some of them will object to our exercise program. And then we resort to the motivation programs. And the best thing I can think about motivation is this book, Atomic Habits, which has sold more than 5 million copies by James Clear, and has been translated into 50 languages. What he tells us here is pick up small habits, make them workable, make them easy and satisfying, and the results will be much more than what you think. It can go up to 37% in a given period of time. And this is our program for the ICU patients. Pursed lip breathing, and we have 16 columns here exhibiting the 16 waking hours. Every hour we want them to do at least for 2 to 3 minutes. The coughing technique, joint range of motion exercises for the upper limb as well as the lower limb, THERABAND exercises, strengthening exercises for both upper and lower limb, cycle ergometer, sit to stand is an exercise, and we want this to be done many times a day. Chair sitting is again an exercise to counter the postural hypertension things. Standing and marching, walking. So the total exercise time that we are aiming for our patients in the ICU is 30 minutes. Not at one go, but bits and pieces, 2 minutes, 3 minutes, and into 5 to 10 times, we get about 30 minutes of exercise. And we aim for 1% betterment every day. In 10%, it's 10%, in 10 days, it's 10%, and 15 days, we have about 15%. The communication board for people who are finding it difficult to talk, particularly in tracheostomy, we have this communication board from the occupational therapy. The occupational therapists will also look into their activities of daily living and help them guide with their, the nurses. Special mention for the psychological care, because we find a lot of psychological issues in the ICU patients. For the family as well as the patient, we have the anxiety, depression, and sleep disorders. And in cognitive, we have the memory, attention, mental processing, and of course the physical rehabilitation part of it. We do use validated questionnaires to find out the hospital anxiety and depression, and also the depression, anxiety, and stress scores. These are the interventions used by the psychologists in our team: positive thinking and affirmations, and the family support. Music therapy, to mention, we have the binaural tone, which helps them to relax well and to cooperate with us. And the meditation, of course. American Heart Association gives us 3 lovely posture coping techniques, and this has been in use for the last 30 years. And all are excellent techniques, top 3 techniques. First one is breathing technique, the second one is on meditation, and the third one on progressive muscle relaxation, which is the Jacobson's technique, which has been in this world for more than 120 years. THERABAND exercises, we teach and train our patients as well as the family relatives to cooperate them with the THERABAND strengthening exercises. We have a case presentation now. This is a doctor from Surat, diagnosed as post-COVID pneumonia with severe ARDS. And in spite of being a patient himself, he proceeded to remove his oxygen support to help an elderly COVID patient in the same hospital. He deteriorated, and a VV ECMO started on the 28th of August. He was treated for 45 days in this hospital and then transported to Chennai. Date of admission at our hospital was 13/9/2020. Already on ECMO and ventilator support, the tracheostomy was done here on the 18th of September, and assembly mode was changed to CPAP soon with 40% FiO2. During the period on ECMO, LETTO cycle exercise machine was started, and active range of motion exercises were given to both upper and lower limbs. Positioning was taken care, plus static quadriceps and hamstring exercise had done. He was weaned off ECMO after almost 32 days. Made him to sit and chair with a ventilator and graded mobilization initiated. Stood on a table on the 3rd of October, maintaining 90 degrees for 30 minutes duration. Made to stand with support, and a gutter frame with a posterior tubal splint and a gutter frame was done. This is the cycle ergometer, and this is the LETTO machine which we are showing. Decannulation was done on the 14th October, and then gradually improved on balance, and he walked with minimal support. Later, walked with minimal support in the corridor for 15 to 20 minutes. He was discharged on 30th October. Home advices on exercises was given to him, and he continued with exercise and regular walking at home. He rejoined work in January 2021 and is practicing his own anesthesia practice in his hometown. This is going to be a game changer very soon, not available in India now, but it is the future. Whole body vibration therapy. This study comes from the University Hospitals of Germany. The present study examined feasibility and safety aspects of using whole body therapy in ICU patients and demonstrated no obvious harm to the patients. Whole body vibration therapy should be considered for use during ICU treatment. It's another green signal from the University Hospital, Brazil. Whole body vibration is a feasible and a safe rehabilitation tool and can be used on critically ill patients. What's prehabilitation? This is another topic here. Prehabilitation is a process of enhancing functional capacity of the individual awaiting surgery. And this from McGill University, Montreal, Canada, states prehabilitation is becoming a recognized means of preparing the patient physically for their operation and or subsequent treatment. Exercise training is an important stimulus for improving low cardiovascular fitness and preserving lean muscle mass. Not to forget the able support from the nutritional optimization programs and from the psychological well-being. So prehabilitation, without any doubts, will help you in many ways with early extubation after the surgery, reduced ICU length of stay, early discharge, and improved quality of life and good functional status. We do use a lot of validated scales. This one on the left is Duke Activity Status Index, which is a self-administered questionnaire wherein we will be able to find out the functional capacity of the patient. And it also gives us provision with formulas to calculate approximately the VO2 peak as well as the METs. And on the right, we find the 6-minute walk test. And most of the some of our patients who are not able to maintain the 6-minute walk test, we can even conduct a 2-minute walk test. So this is before discharge. We sit with them and we tell them and we tell them what is happening with him and what have we done for you, and the same thing to be done at your home. On the diet aspects and on the relaxation aspects, we focus on breathing exercises, meditation, and progressive muscle relaxation. And from the exercise point of view, we focus on the range of motion exercises and ambulation program. We also look into their, the attitude, which can be detrimental to their recovery. Like, for example, short temper, hurried nature and worries, smoking and alcohol, and also on the motivation. We help them to maintain a day-to-day activity record. So, me and my team can help the patients in many areas, especially in stress reductions and relaxation techniques. On exercise front, everything is provided, and to improve the quality of life. Wound healing, if necessary, pressure sores. If necessary, we will be able to do the low-level laser therapy with physical modalities, and pain management with physical modalities like interferential therapy and transcutaneous electrical nerve stimulation and the ultrasound. Fatigue management, improving the quality of sleep, therapeutic lifestyle changes to manage their comorbidities well. Thank you so much.